बोलिए। हेलो चेक हेलो हेलो ठीक उधर से कुछ बोलो।
First of all, on behalf of Anup Master Sports, we have orthopedic association, my father, our team, I welcome you all to the 6th Anup Master Sports and the first live surgery session. So, in the meantime, while the monitors call the
No, Ashish, can you?
call the chairpersons, I think Dr. Vishwanath sir, Dr. Daniel Potter sir, and Dr. Kalpesh sir, the chairpersons. May I have them on stage, please? Is my voice audible at the screen? Yes, sir. Yes, sir. No.
So I would request Dr. Shah. I think Dr. Shah has just gone out after his talk to chair. Ashish, yes, it is audible. Yes, yes, Ashish. Can you hear me? Sudeep here. Ashish, can you hear me? Ashish, can you hear me? Okay, Ashish, yeah, you are loud and clear and visible as well. So, and I'm calling the moderators for this session. Dr. Kalpesha, I think he has just finished his talk, so he'll be back soon. Nishikant, also, I think he's taking some time off. Dr. Deepak Sampath, is he here? Dr. Deepak is here. Dr. Deepak, can you come on the stage, please? And Dr. Upendra, can you come on the stage? And Professor Daniel Edward, please. Sorry, I kept you waiting, Dr. Daniel. Okay. So, Dr. Upendra, is he here around? No. Okay, Ashish, go ahead. Moderators are on the chair. I'll just ask them to speak something in the mic so that to confirm whether they can hear, you can hear them or not. Just speak in the mic. Yes. Ashish. Yes, yes. Yes, yes, Ashish, you are quite audible. Just go ahead. Start your.
I'm very thankful to Daniel Potter sir. He has been my Guruji with his blessings and the blessings of all the seniors. I would like to proceed. And of course, I would like to take the consent of my anesthetist, Dr. Anup ma'am. She is the lead anesthetist. Hello. And Dr. Purushottam, first assistant. Here we have Ravi, Mr. Ravi. We have Shailesh, the main ORPs. We have Hariji and team. And we have 2 MPS from Striker. So why MPS? I'll explain you. So we have Anjali and Parthiban from Coimbatore, Anjali from Haryana, and also we have our theatre team backup. So I would quickly start off with this case. And I have a patient who is a young boy who is roughly 25 years of age, right? 30 years of age, and he has bilateral hip avascular necrosis. So, and we are planning to do his left hip. So I will quickly take you to the robotic screen before I start. So I would like the robotic screen to pitch in the main frame before I take the incision. So you can see the plan here. No, you can see the plan. We have the left. We are seeing a planning which is a city-based planning in the Mako system. That means we have to input the CT in the robot and we'll do the registration. So if you can see the plan, as I can see, we are on a 54 cup size, and the patient has demanded for a dual mobility cup. So we have a 54 cup size and a stem size of 5. And stem neck angle is 127. I would like to the MPS to shift on the assessment using the version 4, please. So we have the version 4. First of all, we plan everything using the sacral slope. So in this case, we had a difference of 10 degrees. So pelvis, the spino-pelvic relationship is normal. There is normal spino-pelvic mechanics. No pelvic tilt, and we have planned a cup supine angle of inclination of 40 degrees, 40, and a version of 18 degrees. May I have the VROM assessment, please? So now we see in flexion. Do it in 90 degrees of flexion. That is what we anticipate. Change it to 90 degrees, please. Standing. So we change and see in every movement. Keep changing and show it to them. How do we analyze? This has all been done while we were preparing the case. 19 degrees, there is no impingement.
Check.
This is what we expect. We can do it more, 110 degrees. Then do extension, 15 degrees. That's fine. So what I'm trying to show you, that before we embark on the major surgery, we see virtual ROM before we go, and adjust the inclination, internal impingement, external impingement before we plan anything. So with so much planning, we then embark on the surgery. I'm doing this case with a posterior approach, and we'll take it from there. And my first hip replacement was done under the guidance of Dr. Daniel Porter, sir. I am very pleased to have him on the dais. And I'll start with his blessings. And you enjoy tea, coffee, and if anything, let me know, I'll arrange at Moria. So posterior incision, I hope everything is clear. Knife, please.
Okay.
May I start?
Ashish, please start. Yeah.
Yes.
If the cameraman can come from top, yeah, so that we can see the end on. So patient is in lateral,
Yes, sir. Patient is in lateral position,
right?
and we have so once we have the, if this should be clear, once we have the TFL, we just abduct the leg and cut the TFL with a dissecting scissors. And this is very important because you
Ashish,
can't go.
can I ask the cameraman if he can hear me, to come show it from the top, the head end at the top. He's showing it end on, which is difficult. We cannot see it. He's coming from the side, so we can only see the finger and the thigh. We cannot see the wound per se. So he has to come from top. ऊपर से दिखाना होगा cameraman को.
तू लगाते हैं.
Yeah, that this is good. And now he has to adjust. He has to come behind your right shoulder or the left shoulder, not from your head. If it is the camera is mounted on the light head, then it has to come from your right shoulder, Ashish.
Hariji, please take care of it. So, before dislocating in any robotic case, we need to put the checkpoint. These are the static points which we put on the posterolateral aspect of the GT. This is what the computer assumes as a fixed point. This is nothing, a small screw. Blade please. Blade please. So after putting the retractor, we check if there is any. Now we will mark it for limb length discrepancy. We take one proximal checkpoint. Capture please. And one point is marked at the patella. Now if this is clear, we lift, zoom it outside, show, we lift it, and we make sure that we see the fat pad, and we gradually, very slowly eliminate the fat pad with a cautery. Very little. It just has to take, you have to take a nick, and I have a right tetra for which I expose the posterolateral muscles. Now there are two options here. If this is visible, which is visible? Either I can put a Langenbeck's short external rotators, hold it, yeah, or, but here you can, if this is appreciable, Hariji, can you show it to them? You can see the glistening posterior short external rotators. I take a tie which is engulfing the uh, capsule as well, and we take a tie and just mark it. There are some bleeders here, so we need to make sure that the bleeders are well. Uh, Now, once we have this in hand, we have the piriformis. I take an incision and my assistant flexes the hip, preserving the sciatic nerve. So my finger is on the nerve and the knee is flexed. And you can see very well. I think there is hypertrophic labrum. So suction please. Dr. Sudeep, is it visible?
Yeah, Ashish.
Any questions till now? We have not touched the robot, it's just the planning. We'll show you the registrations and everything.
It's visible, sir, but the other camera angle was better.
So we can just appreciate the leg moving for dislocation, but we cannot see the hip joint per se because it is showing it from a very close proximity. It has to come from side, elevate and come from at
The
an angle.
voice is not loud of that. Force it please.
Ashish, can you hear me now?
Yeah, I can hear you in a better way now.
Okay, Ashish, the camera has to come from back.
Can we have this top camera?
Yeah, and it has to slightly zoom in from this angle. So, and come slightly from behind, okay? It's right at the top. Slightly from the right
Achi,
shoulder.
Achi.
पीछे से, और थोड़ा पीछे. Much better, much better. Ask him to stay there.
Achi, please. So up till so far so good.
Now everything is visible, Ashish.
Is my wife there, Shilpi? Hello to Shilpi. Please take care of everybody. So far so good. We have just dislocated the head and the foot is facing the ceiling because it's a posterior approach. Now we'll use the 3-point probe to measure the neck cut. This is the thing which is so focus on the big screen, the computer screen. From the LT, I marked the, one second, just a second. LT marked. Yes, please. I have to go up till it comes to green. You can see. Yeah. Somewhere here I get one. So this is a rough neck cut magic ruler. So we had calculated it pre-operatively and I hope it is visible that we are marking the neck. So on the screen you can see that we marked it and I'll reiterate it with the saw, with the cautery and complete my neck cut with the saw. So computer helps us in taking the neck cut, guides us where, because I still remember if you ask anybody what size we have to cut, so my thumb is as the size. They'll say my thumb is as the size of this. So now the next step is doing the neck cut. May I have an osteotome, please? Miller's neck head detector, please. Can you tighten this, please? Usually you have a lot of adhesions, and as I told you that here you have fibrous, hypertrophied labrum in this case because of this avian. Can you take it out from that side? Yeah. So, yeah. Yeah, I've got it. A lot of fibrous adhesions, not exactly fibrosis, but it's the capsule which is well intact. And so anyways, now a cardinal rule is here that you have to measure this, and according to Professor Beverland, the established size, if the cup is alright, sorry, the head is alright, the head would be, the estabulum would be 4 size bigger than this. Reference paper, Professor David Beverland, sir, JVJS 2016. So this is a rough idea, because 48 head if it comes out, so roughly 52. Now comes the exposure of the estabulum. Exposure of the estabulum is an art, and I think you should learn this, what way you do. So we keep the leg at 45 degrees, and may I have the Exeter 1 retractor, please? We put one in the anterior and the bone hook comes out. This is the bleed from the bone, so it will just get better in a wee bit of time. Now, at every step we just make sure that we clean, because we have to expose the estabulum. Now this is Exeter 2. So we put it at the teardrop, sorry, beneath the tal. So you can see that how well it goes inside the tal. And the third is the supralateral exposure of the, so we just started about 5 minutes ago, and 7 minutes on my clock. We are on with the estabulum exposure. So I am taking the lab rub. This can be done with a knife. I hope things are visible. Please let me know. Dr. Sudeep sir?
Yes, yes, Ashish.
Mr. Daniel Porter sir?
Very nice.
If anything going wrong, you may tell me, because the theme is learn, unlearn, relearn. And learning never ends. So, what I believe. So I'll just clear some more. I think we'll divide this. Yeah. It takes 5 minutes, but you should take time and meticulously expose the estabulum in a good way. Now sometimes the posterior part does hamper you, so because you have more of fat in the posterior area, so you have to make sure that you are not injuring the sciatic nerve. It is far away because the knee is flexed, but still we should keep in mind that it is well taken care of. Remove it, please. Shailesh, can we have? Yeah. No. 1 second. So I'll revise one of my retractors. Take out this one. I'll revise this one. That's good. So now we just, can you focus on this 360-degree established view? Is it visible? Audience? Audience?
Yes, sir. It is visible.
So this is important. Now once you have a 360-degree view, now here when we are dissecting, keep dissecting. Once we are dissecting, we come across fat. So that means you are at the medial wall of the estabulum, and that is where your teardrop lies. So we are very well clearing the medial wall of the fat and the medial pulvinar and the fat just above, superior to the TAL. Now a word about TAL. So TAL is the transverse acetabular ligament, which is present in almost 98.6% of the people. And this also we can quote a paper by Professor Beverland that he did 1,000 hips, his dislocation rates was 0.6%, and only his placement of the cup antiversion was parallel to the TAL. So that is a good way of finding one thing. Now I'll remove my detectors because these detectors are bigger ones, and in the Indian subcontinent we have smaller patients. So there are some readers, so we'll just smaller detector, please. So we smaller detector. That's fine. Small detector, please. So I'll take out exciter 2, put exciter 1 just beneath the TAL. So understanding here is very important. दबा दो इस तरफ से. So now, first thing is to check the walls. Posterior wall, anterior wall, supralateral wall, all good. I can feel the teardrop. This is the teardrop, and this is my exposure. So once an exposure is done, we start with registration, because computer will register what is required. So now I request the cameraman to kindly focus on the registration part and put the exposure in the PIP, please. Is everything all right? No questions till now?
So if anybody has any questions, you can come forward and take the microphone and speak.
So, yeah, we are registering the stabulum. See how we are capturing 3 divot points, that is showing the slope and the. So why do we need this registration? Because it is showing, registering the pelvis, taking the coordinates of the computer. So basically you need to understand that a computer is an electronic device which processes data under control of predefined instructions. So once the points are registered and it is in the precision level of 0.5 mm, then only it will proceed. So this is the native anatomy blue point, which is showing that, and it will show how much we are deviated. Now we'll just register the supralateral part so that the pelvis is registered in regards to patient's native anatomy, CT scan. Any questions up till now, sir? So this is only 10 minutes which they take extra in doing robotic.
Anybody has questions can come forward to the microphone, please.
So we are now corresponding it to the main bone, how much we are precise. Like we have done 2 dots which has turned green. So that is making sure that whatever you have registered is in the self limit of 0.05 mm accuracy. So with this, we'll end up with the registration of the. So essentially, if I'll take 2 minutes and to talk to you, in knee and in hip both on the Mako platform, basically you plan, assess, see and then cut. So now we had done everything, virtual range of motion, cup size, and we have a cup size of 54, we'll directly rim with 53 and take it from there. So now the time comes when we ask, roll the robot in, and the robot will come, and believe me, it's the robot which is not doing the stuff, it is we who are doing it, but the robot is only guiding us in a much better, precise way. These are pretty simple cases, but in really complex hips, you need to make sure you have more data in front of you. Like I have the screen in front of me, which is showing me where exactly I am going to place my acetabulum. So can you come in the planning screen, coronal, sagittal and the coronal view. Yeah, implant planning. So you can see, yeah, I have planned other screen, yeah, this one. In transverse, I have planned my cup. I can medialize, lateralize, if you are happy, and I can plan in both sagittal, coronal plane. Please, sir, yeah. So, are you, Mr. Daniel Porter, are you happy with this cup plan?
Ashish, we are unable to see the planning screen.
Please show the planning screen. Yeah. Please show the planning screen. Is the computer screen up? Yeah. So are you happy with the planning? I mean, I have kept it just at the teardrop, taking minimal bone, kept the version inclination 40, 18. I can medialize, lateralize 1 mm, 2 mm, whatever I want. Cup version is 18, combined version 28, cup inclination 40. Now we are rolling the robot in.
So with the top inclination 40, Ashish, a bit of superolateral, your cup will be uncovered. So can you change it to 45 and see whether...
Yes, I can change it to 45. Please change it to 45 and... Yeah, yeah. Yes, please change it to 40. Okay. We can change the cup size. Whatever we want to do, we can do now. So, is this looking great, sir? Are you happy to go with this? 45, 18?
Yeah, looks perfect.
Okay. I'm also good. Can we lateralize 1 mm, please? 1 mm lateralize, please. Just I'll cut less, 1 mm, that's fine. So according to Dr. Sudeep sir and my plan as well, I'm going for 45, 18 and we'll go for it. So now show the robot panel.
Ask him to zoom out a little bit so that we can see the robotic arm coming.
Yeah, zoom robotic arm coming. Focus on this and zoom out, yeah. Let it come in.
Yeah, perfect. We can see the entire robot now.
So these are the green is that we have to take it off. So we put it in the green haptic boundary and we are going in. So we have options of doing a free arm rimming that we do generally when we do manually, but you don't need it. We just planned it 54, putting the cup size 53, and that's it. We have rimmed the cup. So now zoom in here. So robot rolls out. The cup is rimmed, it's resurfaced. It's resurfaced. Hold it from that side. Load 54 cup. We are doing a trident hemispherical cup. 54 trident with MDM for as per the patient. 54 please. So any questions up till now? I have rim 53. Usually, as per the manual, it says rim 50. Either दिखा दीजिए rim 53, 1 mm less. Sir, we have the options of doing manual rimming, yeah, and we also have the options of doing, robotic arm with as we do in generally, like. You're making sure that it is inclination and the anti-version are right, and you rim sequentially. But also you can go for simple single rimming. So both are the options, and now you can see that we are loading the cup on the robotic arm. It will fall in place. The robotic arm will align to the values which we set of 45 and 18 degrees, and we'll take it from there. So, the robot arm is being loaded with the cup. And we'll again have the impaction screen which will show that how much superior you are from, away from the cup, from the acetabulum, and once we impact, we know how much it's going in. So, एक हिंदी में बोलता हूँ, लोग को confusion होता है, एक और ठोको, एक और ठोको, एक और ठोको, hammer once more, and by the time we hammer and suddenly it goes loose. So we are coming with the cup, and we just cleaned. The robotic arm is coming, has come actually. You can see focus here, sir, somehow. Oh, yes. Yes. So now on the screen, can you put the bigger screen as well? 1845.
Yeah, we can see.
Yeah. So
One side.
can you distance? Yeah. Show this big screen. बड़े screen को दिखाइए. Zoom out.
Open the side camera. Side camera goes there.
Okay. The robot locks itself to the position. Now you can put it to the main screen, the robot screen. Put it to the robot screen, please. You can see 1818, 7 proud, 6, 3 proud, 2 proud, 1 more, 0. So actually the cup is now seated. Now show the cup impaction. We'll just confirm the impaction results because we planned 4518. We need to be there somewhere.
Results, please. Yeah, capture.
Capture.
Capture. Capture. Capture.
4419. So actually we have got 4419. So we planned 44, 4518. We got 4419. But I mean, we are there. So if you want to put a screw, we can check it with the probe if there is a bone. So CT view, please. Take a wash, put MDM liner. Yeah. So now you can see the computer screen. Dr. Sudeep, if you want to, I'm on the screw hole and I can see my screw goes inside the bone. So in cases of acetabular fractures, post-acetabular fractures, we see where the plate is and then we take it from there. So, I mean, if the plate is there, we align our cup differently so that it does not hamper the screws of the plate of the acetabular.
You can realign the screw holes according to the plate.
Yes, yes, sir. So now we take a wash, put the MDM liner. We are not putting screws. MDM liner, please. So the cup is well seated. It's we have done a pulse lavage wash. So basically robot or computer is a tool. It guides you to take there. As you can see, you told me 45, I am on 44 and 19. So you're putting the liner. We just cover it because blood splashes on our faces. Now we have a very good dental extraction kit. So we have to check it where it's not coming out because we need to make sure from both superior and inferior, anterior, posterior, the liner is well seated. One gauge piece, one swab inside, please make sure to write it down on the board. And we take out the detectors as we put. So the cup impaction is finished. So we remove all the things. We again use the cobra detector and an artery forceps. Now doing the stem. So stem, you please, cameraman, come on this side, please. So for doing the stem, you have to understand few things, lot of things actually. Because usually I love doing Exeter V40 stems, and mostly I do that. I mean hybrid combinations, but this time I'm doing all cemented, uncemented. So I would like to have a tetra, please. Wait a minute. Good tetra. So first of all, for the beginners, you have the time to Either our finish, please. Just be on this side. You have time to assess, make sure your neck cut is all right. To reconfirm again, now you have the box chisel cut. So now my foot is facing the ceiling. So this is parallel. Now I do 15 degrees anti-version and we use this one as a routine. It's not required. You just have to open the canal. Start trimming is very important. You have to make sure you hold one hand on the knee and go down, extending effort to scrape the lateral border. Yeah. Now we take a scoop, do lateral, taking out of the stuff, right? And then sequential broaching. So as you can see, we are on 5. Stem size is 5. So we go very gradually. These are smoother movements, not harsh. You're just making a pathway. So this was 0. This is striker accolade 2, size 1. It is, now I'm on striker accolade size 2. I need a merit, please. Loose, I come out. May I have the 4, please? 3, sorry. So sequential broaching, and it is very important to make sure. So size 3, it's also loose. May I have size 4, please? Now here what I would like to highlight, when you use your mallet from here, you have more force. If you use it from here, less force. So it depends on the bone and the type of patient you are doing. Well, I am in the middle at the moment. So this is size. We had a planning of 5. So here we need to be cautious. Check. No, we can go one more up, please. Because as per the planning, we had 4. 5. So 4 was loose, but here is there where you check. So now, may I have a swab, this 127 offset? So I'm using a 127, I have option of 132, but we planned and we found combined offset and leg length better with this. Taking a trial, we don't have minus available in this, so we're taking a trial with standard. Okay, we have minus. 0, 0. Okay, we'll have the final stem. Yes, 127, accolade type 2, 2, size 5, please. I need to change my gloves because putting a new implant. Gloves, please. Shailesh, can you let me know the cup size, head size? Head, yeah. Huh? The head size was 49. So as I told you very rightly, 49 plus 4 is 50, 51, 52, 53. So 53, 54 with the established size. So that's what we have planned. So putting in an accolade 2 anatomic stem. Anatomic stem. Is this visible? No. Is everything visible?
Yes, sir, it's visible.
We'll again do a trialing with minus. Final look, Joe. Final. Let's do a trial. Huh? Standard. Yeah, we'll go for standard. Standard.
Go according to the plan, the standard has been planned already. So we go according to the plan. So that is 28,
The injection. Now by the time we do this, I will let you know how do I instill cocktail. I'm sorry I would not be able to offer cocktail tonight because Bihar is a dry state, and Mr. Daniel Porter was asking frankly, Ashish, what do you mean by dry state last night? So we'll explain him tonight that no alcohol, but we do put in our hips. Yes, can we clean the turn union, please, and have the cobra detector, please? So using a aluminum ceramic head, 28 standard as per the plan. Yeah. May I have this impactor, please? Yeah. Just a second, check if anything is inside. Is Mr. Manish Dhawan there? Yeah. So now I'll check the limb discrepancy. We have reduced the hip. You can zoom out and show. I'm having flexion 110 degrees. This is the stability achieved. So yes, sir. Yes, sir. Thank you, sir, for coming here and seeing the live surgery. We'll just check the limb length discrepancy, if any. So we're putting the other hip is also there, so we need to plan. Capture, please. Both hips are gone, so we'll match the other hip according to this hip. Yes. So we have resumed this one as per the actual. 4 mm discrepancy is there. So once zoom on me. So now once we do the next hip that we're doing to next week probably, so we'll plan according to this hip because both hips are gone. We'll do it. But see, show here flexion, rotations, and no issues. So now we'll instill cocktail, that is anesthesia. So I'll just show you one step. We have to lift it to 45 and anterior capsule go inside, pull, push. So this is the way anterior and then other regions as well. So I would like to focus it on because the surgery is over. How much time we took?
35 minutes.
So now, Shilpi, are you there? Hello? Hello?
Ashish, I think she just moved out.
Okay, sir, Sudeep sir, the surgery is over. Another 10 minutes we'll do the closure. Any questions?
So very nicely that you started, Ashish. Any questions? Yeah, there is one. Just hand over the mic to Anup.
In this case, the other hip was damaged, so you got 4 mm of layers encasement. Suppose that hip would be normal one, then how would have you ensured that there is no limit discrepancy by measuring the vertical offset? Because you didn't measure the vertical offset. How much ions you are going to push the stem inside? So how do you ensure the vertical offset?
Right. So actually I told you a little, yeah. No, actually I told you very much earlier that I like to do hybrid. I mean a stem which is cemented. In the cemented stem it is very good and very well judged. But in uncemented, your neck cut should be absolutely perfect. So in cases you don't have robot, you should have ortho view planning software, or even you can take templates and cut your neck accordingly. And make sure if your, see, important thing is that if the leg is 4 mm longer or shorter, it should be stable on the table. If in case you give it a lax, but you don't match the vertical and horizontal offset, and you give a lax hip, so it will dislocate. So what I would say that for normal cases, if leg length is an issue, I would go for cemented Exeter V40 or any cemented stem in which I have got more control on the leg length rather than doing uncemented. In case of uncemented, I will make sure to cut the neck according to the planned size.
So Ashish, in the Mako platform, suppose the other side is normal, we can plan according to the other side.
Yes, sir. Other size normal.
If the other side is also not normal, you must be having an option of changing the limb length
Yes,
by
sir.
n number of millimeters
Yes, sir. Yes, sir.
on the platform.
Yes, sir.
Is that correct?
It is correct, sir.
Madam is here, Ashish.
Yes.
She's here.
Okay. Thank you. Thank you. May I have the mic to Daniel Porter, sir?
Thank you, Ashish, for a beautiful demonstration. When will you get a post-operative X-ray?
Today evening in about an hour before we break off for dinner. I mean, post-operative X-ray. But we
Estimate the extra time of the robotic component to be during surgery.
Sir, see, roughly I started from incision to implantation was 35 minutes on the robotic platform. We saved time by doing single reaming. So I think 16 minutes is the average time, which extra I have calculated in all my cases using the robot. But that is time neutral, they become in roughly 40 cases.
Yes, I agree.
See, in 1 hour I'll be out of this case under all circumstances because closure has already been started, and 1 hour on the robotic platform, 50 minutes on a robotic platform knee, and I mean half knee is done even faster. So I mean my previous speaker did speak that you need more things, infection. Time is not a problem, you don't need more time. In fact, you're more precise, and that is what we aim for, more precision rather than to be fast or slow. But sir, I'm very thankful to you because I did my first hip under your guidance, and I'm able to reproduce things which you have taught me over the last 50, 20 years. So I'm very grateful to you, sir. And thank you to everybody for being there as a spectator watching my our hip. And now we're just doing the closure, and I'll see you in a while. If any issues, our team will take care, and I hope you enjoyed the demonstration. Any still questions?
Thank you, Ashish. No, I don't think there is any question. It was picture perfect, clear and crystal from your side. So thank you very much. We'll sign off from
Yes, I thank my team at the theater, anesthetist ma'am, my team, I mean the whole team. Thank you, cameraman.
your team and everyone.
Thank you, sir.
And we'll thank our chairperson, Dr.
Sir.
Daniel